Okay, we'll reconvene. I'm
I don't think I have met him.
filling in for Kate Bond
last name
and
is
facilitating this
Cornwell.
this panel, and so I wanted to frame it. We've touched on this issue of sustainability and long-term investment, whether we've been calling it a business plan that works or a market model that works, or thinking about the issue of sustainability at the beginning, really, of these partnerships, and we just talked recently in the last session again about looking at the long-term results, even coming back later and measuring. So this panel has been asked to sort of look at the intentional, I guess, opportunities and mechanisms of coming up with sustainable public-private partnerships, with obviously the emphasis on financing as well as probably governance in these partnership models. So our speakers are Soji Adeyi, who is the Director of Health, Nutrition, Population, Global Health Practice at the World Bank Group, and has had experience as well, which is quite relevant to this discussion, as in the Federal Ministry of Health in Nigeria, and also with WHO and UNAIDS. So the second speaker is familiar to this audience, Jeff Sturcio from Raven Martin, CEO of Raven Martin. Soji will talk specifically about financing mechanisms and the role of PPPs, and one thing that was raised yesterday was the effort, which may or may not have been may or not have come out in the end, of the sort of the bank, Gavi, Global Fund, and USAID trying to sort of align at least their funding to promote investment in sustainable health systems in terms of their varying programs. So that was a second area that you were asked to address. Jeff will talk about the private sector sustainability issue, which we touched on yesterday. We'll come back to it. Mushtaq, Vice Chair of BRAC, talking about sustainability, but especially the ability to go to scale over long-term partnerships. And finally, Rajesh, talking about new models and platforms for citizen engagement and community ownership as a vehicle for long-term sustainability. So I think we'll take the presenters in that order. And I think maybe, do you have PowerPoint? You don't?
No,
okay.
I don't.
Okay, fine. So Rajesh, I think, has one when his turn comes. So shall I ask you to go first? You can speak from here or over there.
No, I think, okay, I'll stand up because then
it's a stander-uppers and the sitter-downers.
Then my diaphragm moves better.
That's better. You're more than welcome.
Okay.
So everyone has sort of 7 to 10 minutes, and then we'll have a facilitated discussion, questions and answers.
Good morning, colleagues, and thanks very much for the opportunity to be here and to learn from this audience. And as a colleague of mine at the World Bank who uses the phrase "death by PowerPoint," so I thought, since I'm coming to an audience of health folks, you have life and death on your mind, and I will not inflict on you anything that will increase the risk of death by PowerPoint. So I'm going to be a techno peasant this morning, and we'll just you just bear with me. I have teenage kids, so they call me a techno peasant once in a while. What I would like to do is to embark on a fairly broad sweep with the hope of opening up a space for a discussion, and I'll be more than happy to take lots of questions as you might wish. So before we delve into specifics of financing, can we take a quick look at what I would call the big drivers of markets and trends, the interface in the health market, and of course at the interface between the public and the private sector. Those include, for example, the demographic shift that is happening because we're population growth and a change in the composition of that population. So global population is going to increase fairly rapidly over the next 30 years. Plus, within that, the proportion of the elderly who tend to consume, at least demand a lot of care, will also increase. So that's one. A second driver is just the sheer growth of economies. We know that as income per capita increases, total health expenditure per capita also increases. So it's a very elegant correlation there. But when we decompose the total health expenditure into government health expenditure and private health expenditure, it's not necessarily linear. In fact, it is not at all. What we find is that as countries move from low income status through lower middle income to upper middle income status, in fact, a good chunk of the increase in the health expenditure is private. And a very good chunk of that is private out of pocket at the point of service delivery, which is inequitable and which increases the risk of impoverishing folks. A third element to keep in mind is the anticipated expansion and improvement, if you will, in healthcare infrastructure in the emerging markets, or the so-called emerging markets. And of course, a fourth one, and it is not necessarily the least, is the push for universal health coverage with the attendant emphasis on effective coverage and protection from poverty due to catastrophic costs of care. As if those weren't enough, we also face the realities that there are trade-offs between equity and efficiency goals. And also, we know that there are government failures and there are market failures. And I'm saying this to flag one thing. I don't think it's sufficient for us to say governments must do everything, whether finance everything or deliver everything, because governments do fail. We see that in insurance markets. And at the same time, it is not appropriate, in my view, to over-romanticize the market, because there are market failures. And on this one, I'm with Joe Stiglitz, who said the reason Adam Smith referred to the invisible hand of the market is because the hand doesn't exist. Okay? So we need to be very dispassionate in weighting this thing and not be overly evangelical, if you allow the phrase. So what are some of the opportunities for public-private synergies? One is the inclusion of the private sector in the service delivery within an umbrella that is publicly managed or publicly convened. So if you go out of this room, you go to Turkey, for example. Turkey is making great strides through its health transformation program towards universal health coverage. But it's not all government. In fact, Turkey is, the government of Turkey is interfacing very nicely with its private sector. Just as I was sitting there, in came a news flash of a new agreement between the Turkish government, some private investors, and the International Finance Corporation, a very large health campus in Ankara. Okay? And we have several other examples of this, but in the interest of time, I will zip through this very quickly. A second opportunity is addressing failures in pharmaceutical supply chains. And addressing them might include a switch to the private sector, contracted by the public sector, or even quasi-public entities that are less beholden to the current system in which, in many countries, not everywhere, frankly, there is a lot of, shall we say, extreme rent-seeking in some of the central medical supply systems. A third one is improving the use of appropriate medical technology and equipment. Because I read recently that in many countries in Africa, roughly 40 to 70% of the medical equipment lie idle. So maybe you don't even need to purchase equipment. You really want to purchase the services performed with those equipment, and you can lease from the companies. A fourth one is the potential role of the private sector and human resources for health. We hear a lot about emigration and brain drain, et cetera, but we take a planner's approach to this most of the time. We do not take a labor market approach. And I think we might want to look at just the imbalance between the demand and the supply compared to the populations. And then the interface between financing, development assistance for health, and disease control, because that hasn't gone away. Okay? So, having looked at this, what are some of the recent and, shall we say, current approaches or promising approaches for sustainable financing? I would say if we adopt a working definition of sustainability as the attribute through which a program can continue to be adequately financed from a combination of domestic and global sources, but with progressive shifts towards domestic financing. Then the following, in my opinion, are necessary. I don't know whether they're sufficient, but they are necessary. First, the financing of that program has to be on budget. It has to be on budget, and the country itself has to put down the first dollar or the first yen or whatever it is. A second is that it has to provide demonstrable value. And a third one is that there must be an explicit agreement among the partners, and the prime partner here is the government itself of the country, to progressively increase the use of domestic resources. If those three conditions are not there, in my view, the prospects for medium-term to long-term sustainability are very bleak. Now, in the recent past, and to some extent currently, we do have some large programs that are almost purely bilaterally financed from external agencies. They are not sustainable. I'm not saying they're bad. I'm not saying they're poorly intentioned. I'm just saying that they will not be sustainable, because there's no ownership for them, and sometimes you end up with a game of chicken, in which country says, hey, look, you pushed it, you carry on. So currently, we have quite a few programs, and you know them very well, that are facing very, very steep cliffs as financing dries up. There have also been, in many countries, attempts at some sector-wide approaches. I will not go into any detail. They have their pluses and their minuses. The promise of harmonization, the promise of reducing transaction costs, you have to really quantify those and compare to the counterfactual before you can come to a conclusion about the extent to which the transaction costs have been reduced. They seem to have the drawback of being somewhat weak in terms of an explicit results focus. So this is, you might say, heavy emphasis on process, relative weakness on outcomes. The movement of International Health Partnership, or IHP Plus, did improve on that, and there are some countries that had very good and effective compacts. More recently was a move towards, on the part of the World Bank, what we call the Program for Results, which is still relatively new, and it's essentially what it says it is. It's based on a government program. It's explicitly anchored on measurable results, and it crowds in funds from all sources. And the idea is to try and bring together the promise of being on budget, the promise of being system-wide, and the promise of being results-focused. In the health field, the very first one that we worked on was in Ethiopia. Still a work in progress. Interim feedback suggests that the country is delighted with it, because they firmly are in the driver's seat, and it reduces the hassle with which they have to put up. Perhaps the most recent is the very new global financing facility in support of every woman, every child, and I'll use that as a segue to address Joe's request on attempts by the World Bank, Gavi, USAID, and the Global Fund to come together and streamline the way we work.
Okay, briefly, but I'm giving you more time because we haven't heard from
right.
you and these other...
The promise here is a large-scale use of government systems, but also a very serious emphasis on transitional financing. Okay? So, again, I'll be happy to take questions on that. The final one is a bit of a conundrum, because you asked, there was reference earlier on to changes in the architecture of financing. One with which I was very heavily involved was called the Affordable Medicines Facility for Malaria. And the idea was to bring together the public sector and the private sector, including, lo and behold, the pharmaceutical companies. Okay? To cut a long story short, it did succeed in cutting the prices of antimalarials at the point of consumption. It increased availability even in very distant places. And this was through an independent evaluation. But it also illustrated, in my perspective, the limits of the appetite of the global health financing community for evidence that is not politically convenient. And I'll be happy to say more about that, but I'm just flagging this to say that quite often, collective rhetoric of wanting to be evidence-driven does not stand the test of scrutiny. When there was impeccable evidence of the success of the AMFM, there was not the political stomach for it. Thank you.
I didn't want to cut you off because I think people did have questions about the fate of the effort to align investment for health system strengthening as part of the various funding streams for Gavi, Global Fund, US World Bank, and USAID. Remember there were discussions that were a few years ago.
Right.
We discussed yesterday as to where they ended up. If you could tell us where they ended up and why. I don't want to cut that part off. We can come back to the other question.
Yeah, I think it's fair to say that the aspirations exceeded the achievements for very various reasons. I think you had a situation in which the very architecture of, or the very approach of different institutions were not inherently aligned with those explicit objectives, and also, in my opinion, there were variations. See, there was a meeting of the minds on the objectives, okay? But there are different variations in the capacities of the institutions and the alignment of their instruments, okay? Some, it's all relative. Some are more amenable to being on budget than others. Some are more driven by external constructs or a need to report to the home government or home institution than others. Some have a longer-term perspective than others. The sources of financing varied. So it wasn't for lack of trying. According to the great philosopher Mike Tyson, everybody has a plan until he or she gets punched in the face.
I think you were sufficiently discreet about your description that people will have lots of questions. So thank you very much. Thank you.
Right.
Okay. Jeff. Okay. Everybody's in the standing up. Why not?
Okay, well, this morning I wanted to build on a couple of comments that were made earlier, and in doing so, to pull the lens back from the discussion yesterday afternoon when I was talking more about some of the principles behind successful PPPs and some of the experiences that we've had. And I wanted to build on comments that Sally Stansfield and Devi Shetty made. The first one is Sally started off by pointing out that, and I'll just paraphrase this for my own purposes, if we're thinking about ways to sustain public-private partnerships that will help have a measurable impact over the long term on health system strengthening, one of the things that we have to keep in mind is that marshaling market forces, providing incentives for companies and other private sector players to get engaged with government to improve health systems is probably the best way to have a sustainable impact. So I'll come back to that point. And then I was intrigued by Dr. Shetty's, his entire presentation was fascinating, but there were 2 points in particular that intrigued me. One was that he started off by pointing out the significance of the health economy, that it's about $7 trillion around the world, and so that's actually where I was going to begin my remarks, so I was intrigued that he started there as well. And secondly, as he talked about the way in which Narayana Hospitals has developed partnerships over the past few years, he sketched a methodology that apparently they use, at least as I listened to him, it seemed that what they do is think about their ecosystem and how are they going to deliver cardiac care or cardiac surgery at reasonable cost and high quality. They analyze what gaps they have in that ecosystem, and then they go look for partners who can help them provide solutions to fill those gaps. And that, I think, is one of the things that's missing from a lot of the debate and with respect, probably is also missing from the discussions that you've had in the forum, because what we seem to have been doing, at least the way I was thinking about it until he mentioned this morning, is to think about particular good examples of successful partnerships and then try to build on those. But it may not be that those are the ones that you actually need. And so I thought that systemic approach or a systematic view of filling gaps and finding partners to help fill those gaps is probably another important element of sustainability for public-private partnerships. And then finally, just to signal where I'm going to end up, yesterday I focused more on the private sector side of this. I wanted to just say a couple of other words this morning about the role of government in helping to ensure that these kinds of partnerships are mobilized and sustained. And I'm reminded of an old joke that I think is apt here. You all know about light bulb jokes, or certainly people from the U.S. know about them. But in any case, a light bulb joke about psychiatrists. How many psychiatrists does it take to change a light bulb? Just one, but the light bulb really has to want to change. So, and so the way I think that's relevant is that, how can we get a better complement of public-private partnerships that will help governments achieve universal health coverage, because that's also the context of this discussion. And I think part of it has to be that governments really have to want to work with other partners to try to achieve the goals that they've outlined. So let me just make a couple of additional remarks to flesh that out, but I think those are the key points I wanted to leave you with. So first, the health industry or the health economy. Estimates are that this is about 10% of global GDP. So as we think about the move to universal health coverage, we should be thinking about ways to mobilize all of the stakeholders who are involved in that health economy. And of course, we have businesses who are providing employment and running programs and projects, across the economy. Everything from healthcare delivery to pharmacy care to, we've had many examples of it, as well as, for instance, we talked about health insurance yesterday. Mushtaq talked about microinsurance as well. And so businesses across all industry sectors, while they're contributing to the health economy, are also helping to contribute to health outcomes. And that tends to be overlooked in discussions about universal health coverage. And there are other ways that companies are contributing and can contribute to improving health outcomes in this 21st century world, with management, leadership, and technical expertise, with help on human resources. The technological contributions that they make are what we've really focused on. But in so many ways, different companies and different private sector partners, to put it more generally, can really contribute to the outcomes and the goals of universal health coverage, namely more coverage for more people with financial protection. Now, governments haven't, as government policies begin to be developed for achieving universal health coverage, I would argue that there just hasn't been enough attention to focusing on how to stimulate public-private partnerships to ensure the most efficient use of all the resources that are available to help solve some of these problems. And so that's where I just wanted to make a couple of minor points about ways in which governments can change the way they operate to help provide for more partnerships that will help achieve scale in providing for universal health coverage. And as I said, I was really struck by Dr. Shetty's comments and how that showed that first you have to have it's a question of designing the right partnerships to fill the gaps that you have in health system delivery. So that's one of the points. But there are some simple ways in which government can help to ensure that happens. One is, and these are pretty obvious, but I think it's worth mentioning them in any case. First, there should be a policy of being able to work with the private sector to encourage dialogue and partnerships. All too often, government officials sit in their offices and try to figure how are we going to solve this problem, and all too often it never occurs to them to go out and ask business leaders if they have anything to bring to the party. Just as business leaders wonder who should they call in government if they'd like to get involved. And so I think that one of the things that governments have been doing in many cases, but could do more, is just to make sure that people are encouraged to work with the private sector to find ways to partner and dialogue that will lead to more of that. Also, the session earlier this morning on metrics and information was important because I think another thing that government can do is make sure that there's accurate information about the scale and scope of private health care in the country. In many cases, we just don't know enough about the range of private providers, the different facilities that are available, and all the ways in which the private sector can help with the move to achieve universal health coverage. A third way is to look at, and this is something that often when people from the business community speak, they consider regulation an anathema. At least that's the way that many people look at it. But actually, if you think about it, government's in a position to use regulation, registration, a number of different tools that they have as creative ways to support partnership with the private sector. And certainly we've seen examples of that. I would just say that in a broad sense, the way in which the US FDA has developed PDUFA over the last couple of decades is a way in which regulation has worked together with the private sector to improve the availability of different health solutions. And then also, and this is, again, obvious, but it's something that could be done more systematically, is government can think more about incentives, financing support, and ways to get the private sector involved in public provision in a way that expands the envelope for healthcare coverage. So it's not, I'm not suggesting that government should provide handouts to private sector partners. That's the last thing we would want to see. But there are ways to do this, and so that the overall envelope for healthcare coverage is expanded. A good example of this is one of the suggestions that's been made for dealing with antimicrobial resistance, for instance, which is to use some of the experiments that we've seen in the U.S. and other countries with a transferable right, for instance, in the case of priority review for medicines or vaccines. If you can create a secondary market for a priority review voucher, that actually adds resources to what's available for health research and development, and it also encourages more rapid development of solutions that are needed. And it doesn't actually cost the government anything to provide it, so it has that benefit as well. So in any case, those were a few thoughts on how to sustain partnerships. One, to mobilize and utilize market forces in a constructive way. Secondly, is to think of this in terms of a system, look for gaps in that system and ways that partners can help. And third, that government should just be more relaxed and engaged at reaching out to the private sector to help solve some of the problems that are still going to have to be solved in order to achieve universal health coverage. So I'll leave it there and look forward to the discussion.
Thank you very much. Mushtaq, you're next.
Thank you, Joe. Hello again. Yesterday, we heard many times about the issue of human resources for health. And what I'm going to talk today is really how a very productive partnership to promote community health workers can help and actually scale up and then sustain. We have been hearing about the shortage of health workers for a long time. I had the privilege to work with Joe and Lincoln and many others on the JLI, the Joint Learning Initiative, several years ago, which sort of put a figure of 1 million health workers who needed to be recruited for Africa alone. And then about 2 weeks ago, I think, Jeffrey Sachs organized a conference in Accra called 1 million community health workers. So everybody is talking about community health workers. And yesterday when we were watching the Bragg video, we talked about these community health workers which are kind of a mainstay of the Bragg health systems. We have been training them for the last 40 years or more than that. So what is happening with that? The community health worker idea actually came from China, as you probably know, through the barefoot doctors. And we have adapted this to our circumstances. The Alma-Ata conference in 1978 actually talked about that, and after that, there were a huge number of experiments to train community health workers, and unfortunately, most of those actually failed in many parts of the world. We started training them in the late 70s, and now we have about 105,000 of them working alone in Bangladesh, and another 20,000 working in other countries. Now, what is the partnership? The partnership with several groups. One is the village-based community groups, the microfinance group, for example, who select one of their members to be a community health worker. So it's a partnership with the village community. It's a partnership with the drug companies, because the drug companies provide drugs to the community health workers to sell. It's a partnership with the government health system, because the community health workers refer patients to the government health systems. And recently, it is we have forged a partnership with an American NGO called Living Goods, which is headed by Chuck Slaughter. And through them, we have been trying to replicate that in many countries in Africa. There has been a large number of studies in Bangladesh and elsewhere to see the effectiveness of these community health workers. And we have seen how these community health workers are able to provide treatment to all kinds of diseases, starting from the common diseases to complex diseases like tuberculosis. And they have been able to do that, and they are doing that in large numbers. Also, that there are evidences which shows that the community health workers are also how they are taken by the community, the satisfaction of the community about the role of the community health workers. And also recently there has been a kind of an RCT, a randomized control trial, which was done in Uganda using the BRAC model to see the impact of community health workers on child mortality. And this study done by the University of Stockholm shows that there has been up to 20 to 25% reduction in child mortality because of the work of these community health workers. So it shows that it is working, and we are very fortunate that we are also working with the Living Goods, and together we have been able to get a big funding from CIF, which is the Children's Investment Fund Foundation, which is based out of England, of 15 million pounds, which will allow both Living Goods and us to expand that to many other countries in Africa. So what it's showing that it is working, and it has its own sustainability. So I will close by saying that in the past many of these community health worker models have failed, and one of the reasons why they failed are that they haven't been able to address two issues. One is that these community health workers were trained and then left on their own, and there was no connection with any health system. So you have to have these health workers connected to a health system, whatever the health system is. Even it is a weak health system, they have to be connected to health system. The second thing is the need to create some incentive for them, because in most cases the community health workers are women and from the poorer families. So we the NGOs who have been promoting that, we thought that these community health workers will be working without any incentive, but that's not the case. You have to have some incentive built in the system. So what we have done is that these community health workers are part of the microcredit system. So they have access to microcredit. So that's an incentive for them. Also, in most countries where they are allowed, they are also selling drugs at a markup, which gives them some kind of financial incentive. And thirdly, in places where they are promoting or working on a particular program such as TB, which is funded by the Global Fund, they are also able to get some money by identifying a patient and also providing the dots. So if they complete the dots, then the community health worker gets a incentive for that. So through these, the community health worker model that we have been able to promote is really sustaining within the country, and it is also being replicated in many other countries. Thank you.
Okay, thank you very much. And Rajesh.
So Soji, I have bad news for you. There's going to be a lot of death by PowerPoint. I wanted to actually start by disagreeing with Soji, since I already did once. In terms of this, I think you poignantly said there's a trade-off between equity and efficiency, and that can be true, but I don't think it's necessarily true. And it certainly is not true when you have ownership of whatever you need to be efficient of by the end user, the customer, citizen that's actually benefiting from that service or system. And I think that kind of ownership requires transparency. We all know that the sort of fiscal space is what it is. ODA budgets are not increasing. Tax bases in the least developed countries aren't growing fast enough. And then when you're at the base of the pyramid, private provision is certainly not going to provide an equitable service or system. And maybe part of the answer is, how do you make the money go further? So yes, there are lots of different ways to think about increasing the financing going into the system, but what can we do to actually improve the efficiency of the system? And I would argue that probably one of the most powerful things we can do is to create ownership, and ownership of the community that this system should be serving. And in that sense, we've come a long way in terms of how we've thought of aid, of something we do to communities, and thankfully we're now kind of in a different time where we think about partnering with communities, and I think we're going into a period where we're all working for the community, and I think that's an important shift, and this was referenced yesterday in one of the panels in the morning about the purpose of public-private partnerships. Indeed, shouldn't it be to serve the community? And so, I wanted to share a few different models of what that could look like, things you're familiar with, but maybe with a different lens. So UNICEF is experimenting with cash transfers in a couple dozen countries, has been for a while. What's interesting is, that is a way to think about ownership. Give the family the cash. Poverty is at the household level. Let's not force trade-offs. Surely the family will make the right decisions. And it does actually benefit the health system and the efficiency of that system and the efficiency of capital in that system. We've seen in Liberia that more often than not, you've got the cash being used for transport related to seeking health services. Interesting. We're all familiar with the impact on education and food, but it actually helps the health system as well. And when we think about where this notion of cash transfers could evolve to, Kenya has 45 million people, 30 million have a mobile phone. That's a huge penetration. They're mostly feature phones. Half of the mobile subscribers have mobile cash. Interestingly, half of the phones sold in Kenya last year were smartphones. Now, the phones with mobile cash and the smartphones have very little overlap today, but that's going to change. And suddenly, the ability of even the poorest citizen to have access to information and services and money changes dramatically. You've all heard of Kickstarter, right? You might think that Kickstarter is the largest crowdfunding platform in the world. It actually isn't. They raised about $450 million of cash for people's projects. You know, you want to start a business, launch a product. Last year, the largest crowdfunding platform in the world was GoFundMe. They raised about $480 million. GoFundMe is direct peer-to-peer giving, and the most common cause that individuals and families were raising money for were emergency health expenses, healthcare expenses. Now, this is in the US. That's about a $3 to $4 billion market. Crowdfunding will grow to be an $80 billion market in the next decade. If you apply, and that's just in the US, if you apply the percent of philanthropy that goes to international causes to crowdfunding, about 5 to 6%, right? That's $5 billion of household-to-household giving. That's going to happen in a decade. That's more than Norway's ODA budget. Interesting, right? Where could this go? Now, that's in the future. There's other ways to finance. UNICEF partnered with GE and Frog Design and a few local NGOs to build oxygen plants in Rwanda and Kenya. Oxygen, as you know, the availability of reliable, cheap oxygen is not easy to come by and causes a lot of infant deaths. This is not very good. So GE donated a couple $250,000 pieces of equipment that create oxygen from the air. And then we created local ownership structures. Frog Design, kind of design agency out of the US with a fair bit of experience in emerging markets, created a business plan. We created local ownership structures. The board included the Ministry of Health, the local kind of host hospital that was the primary customer that these businesses started serving, and then a local team who were trained up to run the business. The first thing we realized was there was not enough demand. Now, if this was aid-driven, we'd keep pouring money into this thing. But there was a decision made that there would be no more money. This is it. You guys make it work. So they pivoted and started training healthcare workers and administrators on why oxygen was a good thing, and they created demand, and they moved very quickly, and now these businesses are close to being self-sustaining. Impact investing, by the way, is a $45 billion market today. To put that in context, the US government's ODA budget is $35 billion. Maybe the most powerful thing is to think about not necessarily giving cash, which in the near future is going to happen at scale, or giving equity and ownership of businesses, which is starting to happen at scale, but giving voice. And arguably, this is the single most powerful thing we can do to drive efficiency in the health system or any system. UNICEF has been launching a program called U-Report in partnership with pretty much everyone. It's now running in about 12 countries. And the simple idea is that it's a way for young people to communicate their needs and the needs of their community and to get information real time. So we have almost 1 million youth reporters, U-reporters, under the age of 30 across 12 African countries right now. It's scaling so fast that we'll be at 5 million by the end of next year, and it'll go from there. When we send a question to these U-reporters, we get a 30% response rate. Think about that. That's engagement. In Uganda, a question went out that said, hey, what do you think about corporal punishment in the school system? 99% of U-reporters said, absolutely not. Within 2 weeks, Parliament had passed legislation that banned corporal punishment around the country. We started getting messages unsolicited that actually required a real response, like, hey, I have HIV, my clinic ran out of drugs. The cost of having the M&E to actually know that would be prohibitive. The impact of having a couple 100,000 new reporters in Uganda spread out geographically, not biased by income, priceless. So let me pause there, and I just want to play this video, which is 2 minutes. That'll give you a better sense of what U-Report is. Thank you.
Using simple SMS technology, UNICEF Uganda has introduced monitoring systems that allow communities, including the most marginalized, to participate and advocate for better services at the highest level. One example is U-Report, a free mobile SMS service that engages young people who make up 78% of Uganda's population. Weekly calls are sent to over hundreds of thousands of registered U-Reporters in every sub-county and district in Uganda on community development issues. Responses are received and analyzed in real time. This data is made available instantly and is accessible to all via SMS feedback, the U-Report website, and through television, radio, and newspapers. All 388 parliamentarians are also using U-Report to understand the issues their constituents face so that they can advocate for resource allocation and effect change at a community level. Government is also using this SMS technology to promote accountability and transparency in service delivery. The Ministry of Education and Sports uses EduTrack to monitor the quality of education services. EduTrack, a health monitoring system with an anonymous hotline, allows the public to text in complaints about health services. With the support of the World Bank, the Inspectorate of Government, Uganda's public watchdog, has implemented this core technology to ensure funds reach the people intended, strengthening accountability and transparency. All these systems are breaking down barriers and empowering citizens so that their voice matters.
Great. It's always a good way to end.
Start playing something else.
Are you finished, Rajesh?
Yes, no, I am. I just want to make
Thanks.
sure
Okay.
it goes away.
We had continuous loop yesterday on something different, I think, so this is good. Okay, excellent. Thank you very much. So this is very, lots of different thoughts and options about sustainability. While everybody's getting ready for their questions, I'm going to go back to Soji for a minute to ask just a question. Is the bank consciously, we were talking about this issue, Jeff's issue of developing incentives for governments to work with the private sector, et cetera. Is that in your strategic thinking for either the loans that are given to countries or the sort of policy initiatives, programs that you're putting together through the group? Just talk a little bit about the role of PPPs in your strategy, or promoting them or incentivizing them.
Right, thanks. I'll refer to what we call the World Bank Group, which includes the World Bank, as it's classically known, and the IFC, which is the private sector arm of the World Bank Group. So the World Bank Group has a country partnership framework with each country, which governs what we do together. So the combination of the public and the private sector will be tailored to each context. It's not a prescriptive model. It depends on what makes the most sense and where the country is starting from. So let me continue with an example that I used earlier. So if we're in Turkey, for example, for many years, Turkey struggled to expand access to basic services for its people. I used to work on Turkey in the mid to late 90s, for example. And then for a long spell, Turkey had a very decisive and stable leadership in its Ministry of Health and a serious discourse with the Ministry of Finance. And that really propelled their move towards universal health coverage. But they also see value in the combination of the public and private sectors to help improve service delivery, achieve synergies between the two sectors, drive some innovations. And so they came to the World Bank Group, i.e. through the IMF window now, to co-invest in what I mentioned earlier, which is about 154 million euros, I think, and I think IFC is putting in about half of that, very, very roughly. So that's one side of it. In Lesotho, for example, you've heard about this one very famously in the newspapers. The partnership there was for a hospital, which the management of which was outsourced to a South African firm, and it has improved service quality in many aspects. It's also faced some initial challenges in terms of the cost aspect. So how to summarize this? I think the two most elegant words in the English language are, it depends.
Yeah, but I think, let me push you a little bit, and because I think people who have worked with countries seeking World Bank loans and other things, it's not uncommon, for example, to have themes that people are asked to address. And so I'm going to ask again, I mean, in the sense of, have you thought about mobilizing the private sector or asking people to speak to that issue in their application? You can't force them to do it, but it gets back to Jeff's issue of their awareness or sensibility about the rules of the road, in a sense, which may be constraining this kind of engagement. That was the nature.
Oh, yeah. Well, see, part of what we do, we work with country teams in developing programs that fit within those. So we have internal discourse that, look, if the challenge in a country is to improve the functioning of financial protection or expand service delivery or service delivery quality, when you're working with country counterparts on those programs, please pay attention to both the private sector and the public sector and look for opportunities across the board to achieve the goals that the country wants to achieve. So we take the view that the public sector or the private sector channel, these are means to an end. They are not ends in themselves. And that takes out, if you like, a good chunk of the ideological angst and really focuses on the following. What is the question, what is the problem that you are trying to solve? And I must say that in this case, some of the challenges are structural, because if you're working in a setting in which the financing, the delivery traditionally are public, then it can be challenging to expand that. Some of them, because of limitations on the capacities of some government to actually engage in a dialogue with the private sector. Okay? Some of them, truth be told, come from the international arena. Because what we have also found is that the international public health fraternity and sorority sometimes or often conflates public health with the public sector, and they are not necessarily the same. And that ideological vehemence at the global level among certain global actors imposes certain debates on the countries, and I don't think that is very helpful to the countries, if I may use parliamentary language.
That's very helpful. Very helpful comment. Okay, let me open the floor to questions. Please, if you're in the audience and you'd like to have a question, there's a mic standing there, and you're welcome to come to the table. Just tell us who you are and ask your question.
Hi, my name is Jill Jensen. I'm a student, Doctor of Public Health student from Columbia University. I also did the literature review prior to this meeting, so I'm acting like a sponge. I'm just trying to collect everybody's knowledge and appreciate everybody's comments. My question is about public-private partnerships at the country level and financing mechanisms. So a lot of these PPPs don't necessarily involve major donors that are kind of stabilizing the financing mechanism. So that some of these look more like governments partnering with private organizations at community levels or district levels. So I've seen in the literature and in my own experience what happens when the rise in utilization as a result of these partnerships basically outpace the funding mechanism that has been established for it. It seems that a lot of these rigid budgets don't account for rising costs that accompany rising utilization. So some authors have argued for more flexible financing mechanisms, maybe more opportunistic approaches, and I'm wondering what that looks like, especially since we're talking about rigid budgets, and how do we adjust to and predict unforeseen costs in the future as we start to strengthen or expand health systems?
I think we don't want to get into too much of a health economics analysis here, but I think your point is very relevant in terms of increasing capacity in the private sector. So we'll just really say on this public-private partnership issue and around sustainability, so this would be quite relevant to that. Is that in your field again, in your fielding work again?
Okay. In the interest of full disclosure, one of my jobs is also to seek financing opportunities for the World Bank. So maybe I'll start charging user fees for each of these questions. You're talking to the banker, so the least I can do is ask for money. Well, seriously, on your question, to me it comes at the intersection between scale, having programs on budget, and yes, also realizing that in the short to medium term, there are some things for which countries will have a capacity to finance and some things for which they will not. That is not, in my opinion, a question of this is good or that is bad. It's a matter of practicality. So when some of these enterprises start, and in my opinion, these are useful things, okay, and they gain traction and they grow, we move to the next stage of public policy. Because if you're trying out something in one district or one province of DRC or Bangladesh or Ghana, that's one level of challenge. But if you want to scale it up all across the country, then you move into the realm of public policy in which you had better connect very well with the Ministry of Finance so that it enters the budgetary process and you have a line item there. If you do not have a budgetary line item, it's very hard to get anything done. It's much the same thing as what happens on Capitol Hill here, okay? If the need is not for public financing, then the need is for private financing, but with government regulation, government partnership, or government oversight, depending on how you put it. I think where I will probably push back a little is the connotation of it as rigid budget lines. I'm looking at it now through the eyes of a finance minister, a treasury secretary. He or she has finite resources. So by definition, certain things will be in and some things will be out. That's not immoral. It's just an amoral way of looking at the reality that resources are finite, so these folks have to make some trade-offs. And even though some of my best friends work in the health sector cannot hug 100% of the country budget. Okay?
Everybody's being very quiet. Maybe you're tired, but let me ask another question then. I'll ask another one. And this is, I think, for everybody, really, to reflect on this. Jeff made a provocative statement that at least a good enough regulatory framework for oversight is critical to, in a sense, the growth and engagement of the private sector, especially in a country that's historically perhaps been dominated by a public sector approach and or disposition to public sector services. And I think sometimes it's seen as more of a constraint than sort of a necessity at a baseline level. And I wonder if everybody, because I think Rajesh's notion about sort of crowdsourcing, reality testing of what's working or not working, as sort of getting feedback in a certain way is one point. Mushtaq is dealing with a workforce issue, which could be constrained really by need to register, need to define health professions. So let's talk about that space a little bit from everybody's point of view. Did Rajesh disappear? I just can't see him. There he is. You're hidden by four larger persons. So maybe let me come back to you. Let me ask, Mushtaq, could you start with that around the workforce questions? Because if you get into a lot of licensure and a scope of practice stuff, it's certainly a major constraint in this country in expansion questions.
Well, it varies from country to country. In Bangladesh, for example, there are regulatory issues, but then 95% of the health workforce, is in the private sector and also in the informal sector. although by law they are not allowed to practice, but we know that the village doctors are there all over South Asia. So it's not much enforced. But when we have been training these community health workers, we didn't face much of a problem. But in some countries we are facing problem. For example, in Sierra Leone, we have been training community health workers, and one of the incentives that they get in other countries is by selling drugs with a markup. But in Sierra Leone, these community health workers, the government doesn't allow them to sell drugs without a license. So that's where we are facing problems there, in the sense that the effectiveness of the community health workers is less there because they don't have much income there by working as community health worker. So it varies from country to country depending on what the regulations are and how these regulations are enforced.
Rajesh, you want to comment?
Yeah, so I think the regulatory environment absolutely does matter. So part of the reason that mobile money is not scaling as fast as it could is exactly that. So I think it does matter. Also, if we think about impact investing and social enterprises, the ability to form businesses and the flexibility in those structures matters a lot, especially if you're seeking outside funding. And then when you get to the citizen level, I think it's less the regulatory framework or laws, privacy laws matter, but more around trust. I think if citizens are going to give up information or use their time, then there needs to be a sense of trust that it's both safe and going to have some impact.
Jeff or Soji, right here.
These are challenging questions, but and part of the reason is that we're talking about some, hard and complex issues. There's lots of uncertainty. There isn't enough. There don't seem to be enough resources, and so the global health community writ large has been struggling with questions about sustainability and expansion of coverage for years. I'm intrigued by some of the comments that Soji made about looking at financing in a different way, and I think so. I have a question for you. Does the bank ever consider, when it sits down to talk with its various partners at the country level, what would happen if you thought about not just what's the envelope of public resources available, because most of what we've been talking about are public resources, except for the IFC. I want to come back to that, and ask instead, to solve the problem, how could we use all the resources that are available in the country? And then that sort of opens an entirely different way of looking at this, because it includes the kind of work that Rajesh was talking about, where you can begin now with the widespread use of ICT, that you can begin to think about mobilizing peer-to-peer funding, at the level of ultimately. It's ambitious, and who knows how long it's going to take to get there, but maybe that is billions of new dollars that aren't already available. You can think of all of the money that's available in the private sector at every level in the country, as well as the money that's available through through public resource mobilization at the domestic level, and then you have all the different types of donor funding. But that would give you a much larger envelope to solve the problem with than simply trying to figure out what's the relationship between donor resources and demands and what the public sector in country X has at its control or under its control.
The question of where the road comes up there.
Well, yeah, sure. No, I'm not. Yeah, but I'm just trying to get us to think broadly about, first of all, if you define a larger resource envelope, then you can think about what are the rules of the road, and then some of the things I was saying about how government can encourage PPPs come into play.
Yeah, I think that's a fascinating question. I'll try ahead and say, instead of looking at it from the input point of view, you actually could look at it from the desired outcome point of view. that what kinds of improvement is country X seeking in health status, in terms of service coverage, for example, in terms of the reach and the richness of services in that country. So if one did that, then in my view, your question would be absolutely spot on target, because then it will see the publicly financed part of the health services as one part of the solution, not all of it, which in most cases, that is the reality anyway. It will also come in very useful when we examine the fundamental question: what is the place of government in this anyway? And I want to make a distinction between the source of financing and the route of service delivery, because they don't have to be the same. You can have services that are publicly financed but privately delivered. And I think sometimes the angst, as I said, among the public health fraternity and sorority, nothing against them, some of my best friends are public health folks. The angst often arises from a failure to make that distinction. So, if you press the case and you say government should only really get involved, or the public sector should only really get involved where markets fail, okay? And so, since the private sector, at the risk of overgeneralizing, is better willing to focus on the big urban areas, you might argue that maybe government should withdraw from those areas, the well-served urban areas, or at least de-emphasize its engagement from those areas and really focus on places where the market fails and go to the more remote areas, for example. That is one way of looking at it. You could see it as, I don't want to call it a division of labor, but an interface or interlock of forces. That's one way of looking at it. Back to the question of, and here my initial statement that there is a trade-off between equity and efficiency comes in. Okay, so Rajesh, I hate to restate it, but it is true. Okay, if you're looking at rational allocation of resources, the Minister of Finance, his or her fundamental request is the following: how can I help my country or my government get the most value from the next marginal dollar that I'm investing? That is it. And if you look at it that way, you're looking at it purely from the point of view of efficiency. But if you look at it that way, then you have no incentive whatsoever to start chasing people who are in very distant and remote places where we're going to cost you a lot more money to achieve the same outcome. But because your government, quite rightly, is also committed to equity, then you, the Minister of Finance, you are willing, in the interest of that public policy goal, to spend public money for equitable objectives, but inefficiently. Okay? So, and that is just a fact. It's not a philosophical item. So it's not a question of moral or immoral. It's a fact that if you, the reason why in the Scottish Islands, the UK spends more money per capita, for example, and in the distant parts of Turkey, the government spends more money, is because of public concern, the public policy goal, which is perfectly legitimate. I think as we go into this interface between the public and the private sector, we need to bear this in mind, because the classic private sector actor is more interested in the efficiency arm of it. Let me maximize my yield for the input. For public policy, it's more nuanced. You're willing to engage in more inefficient use of public resources because that is the way you're going to achieve perfectly legitimate public policy goals.
It's really helpful, really helpful. We're running a little over. We started a little bit late, but I'm feeling like I think our last session is really a summary, kind of bring this together. This is a really great, I would say, ecosystem discussion here that we've just had for the platform really on which a lot of our conversations have been held. So let me ask the audience to thank the panel for terrific comments and engagement. That's really good. Sorry you weren't here sooner. Okay, Simon, how do you want to proceed? Want to roll into the next one?